Welcome to the last minute Pulse for NEET PG discussion in our channel Medicine Demystified. So we'll discuss endocrinology. The prolactin is the only hormone from the anterior pituitary which has inhibitory influence from the hypothalamus. It has only inhibitory influence, that is from dopamine. Stalk effect is one cause of hyperprolactinemia, that is any tumor which is occluding the stalk, dopamine will not come from the hypothalamus to the anterior pituitary, so prolactin will increase. So that's called a stalk effect. It is one of the causes of hyperprolactinemia. And about the diurnal variation of hormones, serum cortisol, it peaks at 8 a.m. in the morning and troughs at 11 p.m. to 12 a.m., 2 a.m., that is in the night. Now about stimulation test and suppression test. Glucose tolerance test is done to confirm acromegaly. When glucose is given, it stimulates insulin and it should suppress the growth hormone. So insulin should increase and growth hormone should decrease when given glucose. But in acromegaly, growth hormone will be high despite giving glucose. So glucose cannot suppress the excess growth hormone in acromegaly. The contrary will be in dwarfism, insulin stimulation test. On giving insulin, glucose will become low. Normally a low glucose should stimulate the growth hormone. But when there is dwarfism, growth hormone will be deficient even on giving insulin. So glucose tolerance test is for acromegaly, insulin stimulation test is for dwarfism. Similarly, ACTH stimulation test is done to confirm Addison's. When ACTH is given, normally cortisol should rise, but in Addison's disease, cortisol is deficient. It will not rise even on ACTH stimulation. And for Cushing's syndrome is excess of cortisol, we have to do a suppression test. That is overnight dexamethasone suppression test or low dose dexamethasone suppression test. These two suppression tests will confirm Cushing's disease. Now, what is this high dose dexamethasone suppression test? Once we have confirmed Cushing's disease, we have to find out whether the pituitary is producing ACTH or ACTH is produced from another tumor. So, high dose dexamethasone suppression test should suppress the pituitary adenoma, but it cannot suppress the ectopic ACTH. So, high dose dexamethasone suppression test, if there is suppression of ACTH production, it means it is a pituitary adenoma. If the high dose dexamethasone suppression test does not reduce the cortisol and ACTH, it means ACTH is ectopic. Syndrome of inappropriate excess anti-H, SIADH, causes hyponatremia because excess antidiuretic hormone reabsorbs more water through the aquaporin 4 channels and it dilutes the blood, leading to hyponatremia. So hyponatremia and hypotonicity of the blood. Whereas the opposite of this is diabetes insipidus, where there is deficiency of ADH. ADH is a posterior pituitary hormone. When ADH is deficient, water cannot be reabsorbed from the distal convoluted tubule and collecting that. So water will be excreted. So urine will be dilute, but the blood will be hypertonic and there will be hypernatremia. So usually they say euvolemic hyponatremia is caused by SAADH. Euvolemic hypernatremia is caused by diabetes insipidus. Diabetes insipidus may be central or nephrogenic. Coming to thyroid, if TSH is high, then it means it is primary hypothyroidism. In primary hypothyroidism, T3, T4 will be low. Due to feedback mechanism, TSH will increase from the pituitary. There can be another possibility where there can be a secondary hyperthyroidism. That is, the problem is not with the thyroid gland, but with the pituitary. The pituitary is producing more of TSH, hence T3 and T4 is high. So these are the two possibilities when TSH is high. Either it is a primary hypothyroidism where T3, T4 is low, or secondary hyperthyroidism where TSH is high and T3, T4 is also high. The most common cause of primary hypothyroidism is autoimmune hyperthyroidism, and the most common cause of primary hyperthyroidism is Graves' disease. Primary here means the problem is with the gland itself. Now coming to feedback of the cortisol, mineralocorticoid production is not under the control of hypothalamo pituitary adrenal axis. It is under the control of renin-angiotensin aldosterone, whereas the adrenal sex steroids and the adrenal glucocorticoid, that is cortisol, these are under the control of HP axis, that is by the ACTH. Mineralocorticoid is under the control of RAS system. Aldosterone is a mineralocorticoid. It acts by stimulating the epithelial sodium channel in the collecting duct. Also, it excretes potassium. So, the function of aldosterone is to retain sodium and to excrete potassium. So, in Cushing syndrome, we have moon face, buffalo hump, purple striae. This purple striae is very important. Proximal myopathy. These are the clinical features of Cushing's syndrome. Cushing's is actually cortisol excess. What happens in mineralocorticoid excess? Excess of mineralocorticoid is Conn syndrome. So Cushing's is excess of cortisol, Conn's is excess of mineralocorticoid. There, secondary hypertension, hypokalemia and alkalosis, because mineralocorticoid causes potassium excretion. Now primary Addison's disease. Primary Addison's disease means there is a problem in the adrenal gland itself. So when the gland itself is problematic, both glucocorticoid and mineralocorticoid secretion will be low, and ACTH will increase because cortisol is becoming low. This is by feedback stimulation. So when mineralocorticoid becomes low, there will be hypotension, hyponatremia, hyperkalemia. These are the opposite of mineralocorticoid excess. When ACTH is high, it will cause hyperpigmentation, and hypoglycemia is because of cortisol deficiency. So hypoglycemia is because of cortisol deficiency. Hypotension, hyponatremia, hyperkalemia is due to mineralocorticoid deficiency, and ACTH excess causes hyperpigmentation. So this hyperpigmentation is a very important feature of Addison's disease. Now another disease of adrenal is congenital adrenal hyperplasia, where there is a problem in an enzyme called 21-hydroxylase. Because of this, what happens is the sex steroids become high because cortisols are not produced. Mineralocorticoid and glucocorticoids are not produced. The entire pregnenolone is getting converted to adrenal androgens. So adrenal androgens are high, mineralocorticoids is low. So this causes virilization in females. Virilization in females or premature puberty in males. Pheochromocytoma is a problem with the adrenal medulla. Excess noradrenaline is secreted by the adrenal medulla. It is characterized by headache, palpitation, sweating and episodic hypertension. Men 1 remember 3 P's: pituitary, parathyroid and pheochromocytoma. Also remember another tumor which is gastrinoma. Whereas men 2A and 2B, there are many other tumors. Remember, medullary thyroid cancer is common in men 2A and men 2B. Semaglutide is a new drug which is a GLP-1 receptor analog. Tirzepatide is called twincretin. It is GLP-1 and GLP-1 analog. Both are latest treatment in obesity. Also, they can be used in diabetes mellitus. So, diabetes mellitus, we have type 1, 2 and 3. 3 has many numerical alphabetical subtypes. 3A is MODY, maturity onset diabetes of young. The commonest mutation is HNF4 alpha. 3C is pancreatic diabetes. 3E is endocrine diabetes. Diabetes definition is HbA1c more than or equal to 6.4, fasting blood sugar more than or equal to 126, postprandial blood sugar more than or equal to 200. Values in between will come under impaired fasting glucose or impaired glucose tolerance. This is hyperglycemia. For hypoglycemia, we have Whipple's triad. Whipple's triad is symptoms and signs suggestive of hypoglycemia. Hypoglycemia proved by testing, and the symptoms of hypoglycemia should reverse with glucose supplementation. There are many causes. For example, insulin excess or low intake of glucose is a cause, but insulinoma is also one of the causes. DKA is a hyperglycemic emergency or a diabetic emergency. It is defined by diabetic, that is, diabetes should have RBS more than 250. Ketosis is ketones more than 3 milligrams per deciliter. And acidosis is high anion gap metabolic acidosis. So DKA causes high anion gap metabolic acidosis with bicarbonate less than 18 milliequivalents per liter. Coming to dyslipidemia, we have many types. Type 2 hyperlipidemia is called as familial hypercholesterolemia. This causes tendon xanthomas. At least you can remember this one. Now hypercalcemia, that is about calcium balance. The important point to remember is hyperparathyroidism and paraneoplastic hypercalcemia. These are the two most common causes of hypercalcemia. Paraneoplastic hypercalcemia can occur either due to any osteolytic or osteoblastic secondaries, or it could be any bone marrow tumors like multiple myeloma, or some tumors due to paraneoplastic reaction can secrete parathyroid hormone related peptide. Example is squamous cell carcinoma of the lung. CKD causes secondary hyperparathyroidism. Primary hyperparathyroidism is the parathyroid gland is secreting more of parathyroid hormone. Secondary hyperparathyroidism is, in CKD what happens is PTH phosphate will be high because phosphate is not excreted. High phosphate is the main stimulus for parathyroid secretion than low calcium. So this high phosphate stimulates parathyroid hormone secretion from the gland. This is called secondary hyperparathyroidism. When hyperparathyroidism occurs, it draws the calcium from the bone into the blood. So the bones become thin, fibrotic and painful. That is called osteitis fibrosa cystica.